Welcome to the Impact Education PayerTalkCE program entitled Understanding T2 Inflammation, Spotlight on COPD. My name is Jeff Dunn. I am a pharmacist, and I am the president and CEO of Cooperative Benefits Group, and I will be moderating today's program. This PayerTalkCE program is jointly provided by Partners for Advancing Clinical Education and Impact Education, LLC. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi, and we would very much like to thank them for their support of this program. At the conclusion of today's program, you will be able to complete an evaluation which must be submitted in order to receive credit. You will be able to click on a link entitled Complete Evaluation. This will be in the navigation within the activity. Once you complete your evaluation, you must click Claim Credit to download your certificate, or for the pharmacists who are joining us today, submit your credit to the CPE monitor. At the end of the program, we should be able to describe how T2 inflammation plays a central role in COPD pathophysiology, and we should be able to summarize efficacy and safety of evolving treatments for patients with COPD. I am joined today by Dr. Malin Hahn and Matthew Harmon. Dr. Hahn is Professor of Medicine and Chief of the Division of Pulmonary and Critical Care at the University of Michigan Health. And Dr. Harmon is the Vice President of Clinical Solutions at Employers Health. Welcome to you both.
Thanks for having us.
Yeah, excited to join the discussion today.
Yeah, I'm looking forward to the conversation. You both bring a lot to this conversation, and this will be great for everybody who's listening today. So Dr. Hahn, maybe I can start with you with the first question. And that is, how does type 2 inflammation contribute to the pathophysiology of COPD? And what are the key cellular and molecular mechanisms involved in this inflammatory process?
Well, that's a great question. And if you had asked me this question, I don't know, even 10 years ago, I probably would have said type 2 inflammation really doesn't have anything to do with the pathophysiology of COPD. But our thinking on this, I think, has really changed, certainly over maybe the last 5 to 7 years ago, or 7 years. So, the first question is, what is type 2 inflammation? If you're like me, you may not remember too much from medical school, but, type 2 inflammation is a type of immune system response. And more classically, we've thought about it in association with other diseases, not necessarily COPD. So we think about it in asthma or eczema, or even things like eosinophilic esophagitis. But it's really characterized by dysregulated activity of type 2 helper T cells, or Th2 cells. And the type of inflammation they produce is really driven by a couple of key cytokines. And I think probably some of the most important cytokines to recognize that drive type 2 inflammation include IL-4, which promotes B cell activation and IgE production. There's also IL-5, which is critical for eosinophil survival and activation, which also can contribute to tissue damage and some of the airway inflammation that we can see in both asthma and COPD, and as well as IL-13, which can also contribute to mucus overproduction, airway remodeling, and barrier dysfunction. So, as I mentioned, we really thought that primarily this had more of a role in asthma than we thought it had a role in COPD. But I think over the last few years, some of our thinking on this has really changed. And in fact, studies suggest that maybe even somewhere between 20 and 40% of COPD patients may show signs of type 2 inflammation. So one of the questions is, well, why do we think that's true, and how do we even know that that's true? I think the first place where this really became obvious was as we've done more studies simply on inhaled corticosteroids and trying to understand which patients respond to inhaled steroids, we realized that blood eosinophils actually can help us identify patients that respond better in terms of exacerbation reduction. And here it's, if you look at the GOLD document, it would suggest that it's maybe there are categories, but really it's a linear relationship. And the higher the eosinophil level, the greater response we see to inhaled steroids. And so I think that was maybe sort of the first hint that type 2 inflammation was potentially important in COPD. But there's really been more and more data and accumulating evidence, which we'll talk about here in a bit, but really suggests, based on some of the pharmacologic interventions that we've tried that really target type 2 inflammation in COPD, and we're beginning to see a subset of patients characterized by high eosinophils really do have a differential response, particularly patients who have eosinophil levels of 300 or more. We know these patients have higher risk for exacerbations, better response to inhaled steroids. And then, like I said, as we're going to get into, the data really suggests that these patients have differential responses to drugs that target specific cytokines that are part of the type 2 inflammatory pathway. So I think that, it's really becoming clear that a subset of patients with COPD, do have this kind of distinct phenotype with, distinct clinical characteristics and likely distinct treatment options. I think one of the questions that I often get is, well, aren't these really just asthma patients, or aren't these just asthma COPD overlap patients? And I just think it's important to point out that some of the clinical trials that have been done in the last few years that have been studying, again, very specific targeted type 2 anti-inflammatory therapies, all excluded patients that had any kind of history of asthma. So these COPD patients I'm talking about that have type 2 inflammation may not be the ones that our clinicians are thinking about when they think, oh, well, I've got these patients that look a lot like asthma but have some fixed airflow obstruction, and it's these asthma COPD overlap patients that are the patients that were studied in these clinical trials. I think it's important to realize that actually those patients were specifically excluded from those clinical trials. And we're really talking about patients that look very much like any COPD patient, except for the fact that they're often characterized by high levels of eosinophils and more frequent exacerbations, and again, kind of these unique responses to medications that target the type 2 inflammatory pathway.
Great, thank you. That was a great overview of the pathophysiology and the role of cytokines in COPD. Keep me honest here, maybe I can try to summarize this for our listeners. You mentioned that 20 to 40% of COPD patients show signs of T2 inflammation. Are they identified through the eosinophils, or are they easily identified?
So there's a couple of things that likely characterize these patients. We have seen studies on blood eosinophils, sputum eosinophils. Other potential biomarkers include exhaled nitrous oxide, or FeNO, as well as IgE. But to be honest with you, I think the best one that's most widely available, in particular because FeNO, first of all, is not yet, I would say, widely available in the average clinical practice. And then second, in the COPD patient population, the values can be altered by active smoking. And so it can be a little bit more difficult to interpret. So because of those, I would say, generally speaking, that the blood eosinophils are going to be the best way for practicing clinicians to try to identify these patients. I'm hopeful, though, that we'll have even better, probably more specific, more stable biomarkers in the future. But for right now, I would say that blood eosinophil levels are what kind of the most accessible biomarker we have.
That's helpful. Thank you. So I think that's important to both providers, but also payers who are studying formularies. So how would you help us understand how these mechanisms potentially influence therapeutic strategies for managing COPD? So again, that could be from a provider perspective or payers from a formulary perspective on how we're providing access to these medications.
Yeah, so I think this is actually a really good point. So as I understand it, our payers may view this differently, but as I understand it, the FDA really treats the overlap patients as asthma. And they think those patients are kind of already covered. and should be covered. And so, in my mind, I'm kind of lumping the patients, that maybe have that smoking history and some fixed airflow obstruction, kind of that prior history of asthma, maybe that eczema as a kid, et cetera. They look very much like asthma. And sometimes we'll call those COPD, asthma overlap. Those patients, I think, are already sort of included, in my mind, in the asthma group that was kind of already studied and clearly benefits from targeted therapies from type 2 inflammation. And I think many doctors, even before some of the newer therapies were approved for COPD, were already treating those patients with some of these newer biologic targeted therapies. It is important, though, I think, to recognize, though, that the word asthma COPD overlap does not mean the same thing to all people. And in fact, GOLD is really shied away from using that term, generally speaking. There is the patient I just described, right, that maybe has a long-standing history of asthma and then has some smoking history and develops fixed airflow obstruction, and maybe has a little bit of emphysema. And maybe for some, that's the first patient that comes to mind when we think about asthma COPD overlap. But if you talk to other people, they might say, oh no, they might think of the patient who's had very, very severe asthma since birth and maybe a teeny bit of smoking history, but developed very severe fixed airflow obstruction, and actually, in point of fact, has no evidence of reversibility and doesn't respond well to steroids. And in their mind, that's the COPD asthma overlap patient. So I think there has to be some recognition that it's not necessarily the quote unquote overlap piece that's going to drive whether a patient responds or doesn't respond to some of these targeted therapies, but rather it's going to be looking for signs of type 2 inflammation, which, may be eosinophils, and certainly in non-smoking patients, the FeNO can also, I think, be really helpful in trying to identify, these patients that are again more likely to benefit. And some of the parlance that we've used, or that some of the scientific community has used to try to cut through some of this confusion about what is COPD, what is asthma, and is the idea of treatable traits, where maybe because there has been some diagnostic confusion, maybe we need to get a little bit away from that and think more about just, is there presence of type 2 inflammation? And therefore, in this patient with airway hyperreactivity, they are going to be more likely to respond to targeted therapies. I realize, however, there is no ICD-10 code for treatable traits or for type 2 inflammation. So we are still stuck mostly with, the clinicians being forced to check a box that is either asthma or COPD, which will be swayed by a variety of factors. But in my mind, it's sort of this, again, it's the elevated eosinophils and FeNO when it's available that help to identify the patients that respond to the biologics.
Thank you. And I'm actually glad you mentioned a little bit of the struggle between asthma and COPD, because from my perspective, with my payer hat on, there is definitely some blurred lines there between the two. And a lot of the drugs actually have both indications. And a lot of the biologics that we're going to be talking about, maybe have one, but, we know what's coming in the future with expanded labels. Yeah. So, we would welcome more information and more guidance on how we find the right drug for the right patient at the right time. And so targeted therapy approach would be welcome and fantastic. Because at the end of the day, we want to minimize side effects and increase efficacy and find the right drug for the right patient. So this is all important information. So thank you for that great overview around the pathophysiology and the different cytokines. But how would you explain or answer the question around what the clinical implications are? So symptom presentation and patient quality of life. What is the role of T2 inflammation there?
So we know that patients, for instance, that have higher levels of eosinophils are going to have For instance, 1.76, I happen to have the figure in front of me, greater risk for severe exacerbations. They have more impaired lung function. And when we, for instance, do CT scans on them, one of the things that's getting a lot of attention lately is the presence of mucus plugging on CT scans for these patients, which is interestingly associated with independently associated with increased exacerbations, but may or may not be identifiable based on increased copper sputum production. For some of these patients, these plugs are somewhat silent in that they're not complaining of, necessarily mucus production, but there certainly is clinical impact with respect to being at risk for increased exacerbation. So these patients are definitely sicker and definitely have higher need for more frequent use of systemic steroids. We really try to get away, or GOLD does not recommend chronic oral steroids for any of these patients, but I think we've all seen patients that come in somewhat stuck on oral steroids and we're unable to get them off, which obviously is associated with a lot of side effects over the long term that we don't want, such as osteoporosis, diabetes, cataracts, et cetera. So there's unfortunately, even the inhaled steroids can sometimes have some side effects over, the long term. So I think, the potential clinical impact of targeting the type 2 inflammatory pathway for these patients would be hopefully lower overall use of systemic steroids, better symptom control, fewer exacerbations, and from a payer perspective, fewer hospitalized exacerbations, which obviously are one of the most expensive bad outcomes that we want to try to avoid in COPD.
Thank you. So you've mentioned exacerbations, FEV1, other outcomes. I think we understand that. I think I heard, though, that patients with T2 inflammation do have more exacerbations, or at least are more prone to more frequent exacerbations, right? Okay, so how would you kind of define then the long-term outcomes specifically around T2? So again, I think we understand, the goal of lowering exacerbations and those types of things, but when we talk about T2 inflammation specifically, how do we tie that into an outcome? Is it about the exacerbations?
Well, that's where we have the most data for right now. I mean, particularly in COPD. I mean, the main study that we have right now, or the main studies are the ones that were done in dupilumab, which ultimately led to FDA approval. The headline results from the mepolizumab studies were released, but that has not yet received FDA approval. But we don't have long-term data. I mean, what I'd love to be able to tell you is that if we initiated these drugs early, that there were either fewer deaths or there was slower decline in lung function over time. It is entirely possible that is the case. We don't have any long-term data to demonstrate that. One thing we do have, though, that was interesting. Now, granted that the data was in asthma, but the Vestige study was done where they looked at dupilumab in asthma, and they were able to show improvements in some of the CT metrics, particularly less mucus plugging. So I think that there definitely is some thought or hope that perhaps, with reductions in airway inflammation, that you might even be able to prevent remodeling over long periods of time. But I have to admit that we don't have that long-term data yet. So hopefully we'll get there, but we don't have it yet.
Thank you. So I'm going to ask you in a minute to maybe dive into some of the drugs specifically. But, high level, is there a strategy around the different cytokines and, picking one over the other? I mean, is there specific MOA that is shown to have a better impact in T2 inflammation and COPD?
Well, it's a little bit challenging, as right now we only have one drug that's approved. So that's, I think what you're getting at is, let's say we have 2 or 3 drugs that are FDA approved, and then how are we going to ultimately decide which one is the better one for patients and which patients? It's a little bit challenging when the inclusion criteria are all the same. That's usually what one of the things. But I think as far as I know, the results of the mepolizumab studies are not available yet, but we do know, at least from the dupilumab studies, that these medications can not only result in exacerbation reduction, but they also result in symptom improvement and lung function improvement.
Again, thank you. I'm going to shift gears a little bit and ask you, Dr. Harmon, to chime in here, if you don't mind. So hearing all of this about, T2 inflammation and its role in COPD, and high level, before we jump into the data around the drugs, the MOAs and the interleukins and again, different pathways here. What are your thoughts around place and therapy of the biologics, or the biologic we have and then potentially the biologics in the future?
Sure, yeah. From a payer perspective, COPD really hasn't been a major focus. A lot of the plan sponsors we work with, I think it really presents a significant and growing challenge. It's one of the leading causes of morbidity and mortality worldwide. I think it's projected effect over 600 million people by 2050. I think 31 million of those are Americans. So, a key concern is that disproportionate growth in the disease prevalence among women and low to middle income population. So how do we think about that from a population risk stratification side of things and barriers? So, trying to minimize the impact on those patients and utilize the healthcare resources effectively. So, as Dr. Hunt mentioned, we look at type 2 inflammation and COPD. We really see an opportunity for targeted intervention, with the 20 to 40% of COPD patients exhibiting T2 inflammation. And, as discussed, that subset really has more frequent exacerbations. So we're leading to those costly hospitalizations and that increased systemic steroid use. So we want to try to avoid that and some of the higher rates of that symptom persistence and disease progression. So, with the introduction of the biologic therapies, targeting T2 inflammation, like I said, just one now, but looking forward to when we have multiple options. We really feel like that represents a shift toward precision medicine, something I'm excited about for COPD, because I really, it seems like these drugs offer the potential to reduce those exacerbation rates, decrease that steroid dependency, and improve long-term outcomes for patients with eosinophilic COPD. And from a cost perspective, this is critical. So COPD-related hospitalizations can cost anywhere between $10,000 and $15,000 per event. So if we could prevent those exacerbations through targeted therapy, I think payers stand to see significant cost reductions. So, that said, I think payer policies need to really evolve to ensure that the right patients are getting these treatments. So I know we'll probably dive more into that in our next track and best practices, but I feel at a high level, look at a few things. So make sure the coverage pathways are based on biomarkers. It sounds like the blood eosinophil counts of over 300 cells per microliter is where really that's the recommended for the emergent treatment guidelines. Maybe should incorporate some step therapy adjustments. So while the ICS LABA/LAMA remains the first line approach, I think delaying access to biologic in those high risk patients could lead to some preventable exacerbations and higher overall costs. So how do we risk stratify appropriately? I think there's been some models out there we can talk a little bit more in depth later on. And then the third one's some value-based reimbursement models. So are there ways that we can ensure the biologic manufacturers are held accountable for some real-world outcomes? That's in the ideal world. So potentially tying reimbursement to some exacerbation rate reduction. So ultimately, we need to balance that cost effectiveness with ensuring that the right patients receive the right treatment at the right time.
Great answer. I love that. Thank you, Dr. Harmon. And to your point, we'll probably talk more about the collaboration and other opportunities to work together and de-silo ourselves and address risk and other things, in a subsequent conversation. But those are all great points. And that's what I really find valuable about conversations like this, is we have different stakeholders at the table and we're talking through this and hopefully coming closer together to each other. But you also, I think, said it really well in that we would love to have the ability to say, based on X, Y, and Z characteristics of a patient, this drug is better than another drug, and then ultimately have some disease modification and eliminate or significantly reduce exacerbations. So, all good things we're working towards. But again, these types of conversations are super important. So, Dr. Hahn, I'm going to pivot back to you now, if that's okay, and I want to ask you if you will address something that we've teased a little bit up to this point, and that is, can you speak a little bit in more detail around the therapies, and I say that plurally, the therapies that are going to be involved in potentially improving the management of COPD and T2 inflammation?
Sure. So we've got a lot of things that are sort of in various pieces right now. Some of the earlier studies that people may remember, there were some earlier studies on two drugs that target the IL-5 pathway. So those include mepolizumab and benralizumab. Mepolizumab actually more specifically targets IL-5 itself, whereas benralizumab targets the IL-5 receptor. But those studies, that they both were in phase 3 programs, and both were negative for reducing exacerbations, which led both molecules back at the drawing board. And to be fair, the eosinophil counts that were used in those studies were probably too low for COPD. They were probably appropriate for asthma, but really we're seeing for patients with COPD who have strong response to at least these particular molecules, it likely requires a higher eosinophil threshold. So at least mepolizumab, the study was repeated, and again, that high-level data has not been published. It's been released as a press release, suggesting that they did hit their primary endpoint, this time targeting patients with eosinophils 300 or more, which post-hoc analysis of their prior data suggested would work, and in fact it did in prospective studies. So, but we still haven't seen the full-out paper yet. So I'll be anxious to see what that looks like, and as well as to see, how ultimately the FDA responds in terms of approval. Now, there's also dupilumab, which works a bit differently. It targets the IL-4 and IL-13 cytokines. So a different portion of the type 2 inflammatory pathway. And the evidence basis for that, the two phase 3 studies for dupilumab were Boreas and Notice, which were published roughly a year apart in the New England Journal of Medicine. And they showed overall, they met the primary endpoint, which was a reduction in the annualized rate of moderate or severe exacerbations of COPD, I think. And the two studies, Boreas and Notice, were fairly similar in terms of the, both inclusion criteria and effect size. They also were able to show improvements in symptoms as well as lung function. So this did lead to FDA approval for dupilumab, specifically, again, patients who have eosinophils of 300 or more, which was, based on the study design from that particular trial. So that, I think, is good, and it's exciting from a physician perspective to have. To be honest, we had not had, I think the last new therapy that we had for COPD, I can't remember the exact year it was approved, but probably 10 years ago, was roflumilast. And unfortunately, overall, I think use of roflumilast has been limited largely due to GI side effects. So if you put roflumilast on the side, we really have not had a new therapy for COPD outside of just reformulations of inhalers in a very long time. So as a physician and patient advocate, it's exciting to me just to have something new. And I think hopefully it sends a message to, other people doing research that we actually, with good molecules targeting, specific pathways, using specific biomarker, that we can actually make a difference in this disease. And so there are, fortunately, a lot of other studies with other drugs, I think, that'll be coming down the pipeline, targeting not just type 2, but others as well. But, as far as MEPO goes, we're really still awaiting that primary publication.
Thank you. That was helpful. For the people who are participating today who haven't looked at the guidelines recently, Dr. Hahn, do the clinical guidelines in COPD address T2 inflammation effectively?
I think so. I hope so. What I will say is, maybe this would be a good opportunity for me to clear up a common point of confusion about the GOLD recommendation. And that is, there are actually two different algorithms, one for initial diagnosis and one for follow-up. And And I think people tend to keep using the initial diagnosis one and not realize that if the patient's already on something, you need to forget the ABE categorizations and go directly to the follow-up algorithm. So, assuming most of these patients that are going to be started on a biologic, for instance, are probably already on therapy. The real question is how is this addressed in GOLD? Well, it's really on the exacerbation pathway where I think the eosinophils and trying to identify these patients are more important. So if you look at the follow-up treatment guidance from GOLD, there's the left-hand side of the pathway. They explain what to do about medications and how to escalate if the primary concern is dyspnea. If it's exacerbations and dyspnea, you follow the right-hand side of the graph. But it's a little bit difficult to fully verbally explain. But as you go down that, it's clear that they have specific spots for, if eosinophils are over 100, this is where you consider adding inhaled corticosteroids because that's where most of the benefit is. And then if patients are failing triple inhaled therapy and have eosinophils over 300, right now you would move to dupilumab. So I think that's kind of how that's being addressed in the document currently. Obviously, if mepolizumab or other drugs get approved, we'll get those added to the document as well.
Fantastic, and a great call out. Thank you. Dr. Harmon, let me ask you from a different perspective. What do you think the potential is here, both to improve outcomes and maybe to decrease resource utilization with both the updated guidelines and the newer therapies that are coming?
Yes, I think this is where we see real opportunities for payers to drive meaningful change. We know that COPD severity and frequent exacerbations are primary drivers of healthcare costs we've discussed. So, a patient experiencing multiple exacerbations per year is twice as likely to require ICU care and twice as expensive to manage compared to those with controlled symptoms. So, with the 2024 GOLD guidelines now incorporating the blood eosinophil counts into treatment decision-making, and payers have the opportunity to refine those COPD management strategies. So, what does this mean in practice? I think, let's break it down into 5 different ways. So, how about number 1, reducing hospitalization and ER visits? So, those high exacerbation patients account for over 50% of COPD-related healthcare costs. So by proactively identifying those eosinophilic COPD patients and initiating targeted therapy earlier, we can hopefully prevent those hospitalizations and lower the total cost of care. Number 2, I think just want to optimizing those outpatient management and transitions of care, I think is crucial. So patients who receive the guideline-directed therapy and structured follow-up after exacerbations, tend to have lower readmission rates. So making sure those patients are not lost in follow-up, in our complex healthcare system that we have. So health plans can really incentivize pulmonologists to implement, some of those GOLD-aligned treatment plans and support some earlier biologic intervention when appropriate. Third, I'd say, aligning coverage policies with the real-world evidence. So payers, really, we want to move towards outcome-driven reimbursement models. I think, for example, you could have a performance-based contract where reimbursement's tied to 30% or more reduction in exacerbation rates. If patients met that threshold, the payer covers costs. If not, the manufacturer provides some sort of rebate. I think that approach would help ensure that we're paying for treatments that deliver measurable clinical benefit. I've also heard some leverage of AI-driven risk predictions. So, there's predictive analytics can help flag those high-risk COPD patients based on the claims and pharmacy data. I think, Anthem has some good data out there that they've already reduced hospitalizations by, I believe, 20% using some of the AI-driven case identification. So maybe that's something that could be adopted more across the board. And then last, I'd say incentivizing some of that high-value care for COPD management. Some of the bundled payment models could reward pulmonologists who successfully reduce exacerbations in high-risk patients. I know there's the care coordination model. I think there's some data potentially that, like an 18% cost reduction by aligning incentives with guideline-based cares. I think ultimately the future of COPD management isn't just about approving the latest treatments. It's about ensuring we're using the right tools to improve patient outcomes while controlling costs. So by aligning our payer policies with updated guidelines, leveraging that real world evidence, we can really, significantly lower the healthcare, resource utilization.
Those were great comments and really a good summary. So I would like to thank both of you, Dr. Hahn and Dr. Harmon, for your comments and commentary and really great education. And I'm really excited that we have time for the audience to ask both of you questions. So at this time, let's jump into that and we will address the audience questions that have come in. Going to direct the first question to you, Dr. Harmon, and then I'll jump in as well. And the question is, how are payers addressing medication non-adherence in COPD patients?
Yeah, I think that's a great question. It's something that we're trying to focus on quite a bit, since we know that COPD adherence is not great, similar to what we see in asthma. So I think there are some strategies that are being implemented to improve that. As a pharmacist, I love pharmacist-led adherence programs. So you see some health plans offer that medication therapy management, the MTM services, where pharmacists can check in with patients to reinforce proper inhaler use and adherence. You could even offer some direct pharmacist consultation at no cost for those high-risk COPD patients. So going back to the data analytics piece of identifying those patients and then referring them to a pharmacist. I think there's also great care coordinators that can help in that space as well. And just some of those reminders that identify what is the true cause for lack of adherence. Is it due to the technique? Is it due to cost? Is it due to forgetfulness so that we can create reminders, or is it just due to mistrust in the system? So I know that's also a factor now, unfortunately. So trying to get to that root cause, I think, is essential, because we know not everybody fits in that same box. We talked a little bit about the digital health and those smart inhalers. I think covering some of those connected inhalers to track adherence, to really know what's going on and ability to send reminders. I know there's potential connectivity with apps now. That could be a potential way to address that. And we've seen some of the digital tools have shown to increase adherence rates by about 20 to 30% in some studies. You can also think about from a copay perspective for those high value medications, if cost is truly a barrier. So yes, it's particularly with the biologics, there are the copay assistance programs to reduce those costs. And if you get it with an exclusive specialty arrangement, potentially you could get it at $0 coverage. So that's one additional way we've thought about it. And I think really trying to be proactive as much as possible. And when those patients are newly diagnosed, to get them to understand the importance of their medications, also really key.
Thank you, Dr. Harmon. And I like the insight there into actually trying to identify the root cause of the non-adherence. That's important to understand the motivation and the driver of the member or the patient. But the more I look at this question, I think there's a lot to unpack here. It's a very nuanced question. Mm-hmm. Adherence in general, I think, is a role that the payer can have. And you mentioned it, it really should be part of an integrated care management program. And the payer has an opportunity there, given the amount of data we have and knowing what the patient is doing elsewhere, but really digging into the driver of that non-adherence. I also would just say that I think the focus is really on adherence with the inhalers before you move on to a biologic, and that's a step therapy in the PAs. And then once you get to a biologic, maybe it's a different question: is how focused are we on adherence to a very expensive biologic? I would say if we're paying for those and they've got to that point, we should treat that the same way we're treating adherence with the inhalers. But great insight on the driver of the non-adherence and trying to identify that. But the payer definitely has an opportunity, and I will call it an opportunity, to improve outcomes with our members. Dr. Harmon, let me start with you on this question as well. So the next question that's come in is, given the cost of biologics, how do payers determine their place in therapy for COPD?
Yeah, I mean, that's a fair question, and honestly, ones that payers are still working through. I think that biologics represent significant costs, so that challenge of figuring out how to integrate them within COPD treatment is make sure that they're both clinically appropriate and we're still financially sustainable is key. So I think step one is following the data. So we look at clinical trials, the real world evidence, some of those guideline recommendations, I know we'll talk about in the next talk track on Monday, where we try to identify the patients that benefit the most. So as Dr. Hahn mentioned, that strongest evidence are for those patients with those high eosinophil counts and those frequent exacerbations, despite being on the triple therapy. So, and then defining that right patient population really is key, since biologics aren't for everyone, and will typically require some documentation showing that patients have had at least 2 moderate, maybe 1 severe exacerbation in the past year. They've already tried and failed triple therapy, or that they meet that eosinophil threshold. If they check those boxes, and I think the biologics really become an option. If not, the classic the ICS or LABA/LAMA remains the go-to. But really that price is the big hurdle. So when you're talking up to potentially $25,000 per year, we want that assurance that they are actually going to reduce hospitalization. I think the data has started to portray that. So as we've talked a little bit about really negotiating contracts with manufacturers to achieve the lowest net costs, if we're able to get some value-based metrics, even better, to really show that those biologics will deliver on the promises there. So it kind of shifts some of the financial risk off the payer and on the drug maker. But we do know there's challenges there when you're trying to connect the data on the pharmacy side and the medical. But at the end of the day, it's all about that precision medicine. And we know they aren't going to replace standard therapy, but for the right COPD patients, they can be a game changer. So we're trying to work through ways to make sure we're not denying the right patients at the wrong time.
Thank you. And I think this is an actual situation, which is not always the case, where PAs and what we're doing is in alignment with the guidelines. So, looking at a typical PA in the industry, it really is, are you quote unquote uncontrolled as defined by an exacerbation on compliant inhalers? We are looking for eosinophil levels. Dr. Hahn kind of talked about the importance of that in this particular space. And then ideally, I think a lot of us would want a specialist involved here once we get to this point. So I think that's pretty consistent with the guidelines, fortunately. Next question. I'm just going to read this, and I'm not going to use names here to call people out, but I'll just say, Dean, if we don't answer this question, please send in any kind of clarification. So I'm going to open this to Dr. Hahn and Dr. Harmon. The question is, will there be ways to move T2 inflammation markers or other markers to a pharmacy or patient-based or wearable site of care for tracking effectiveness of treatment? So can we, again, leverage these markers and actually have other people like the pharmacist, where they're maybe filling these medications, can they be more involved in following up these patients and tracking them and evaluating effectiveness, adherence, and all of those types of measures?
Right now, the primary biomarker that we use to define whether patients are eligible is blood eosinophils. So if that is something that we could do locally at a pharmacy, if that could be sorted, which it probably could be, then I would say yes. Another marker that may be helpful, but is impacted by current smoking, unfortunately, is the FeNO. And so that potentially also could be done, but it requires some caveats with the interpretation. Right now, there's not guidance that these biomarkers should necessarily be tracked over time, or that the relative drop in these biomarkers can be equated with clinical efficacy per se. It's probably related, but we don't really have a lot of data. So I don't actually think clinicians are going to be checking those specific biomarkers to see if the drugs are working necessarily. They might check them if they are wondering clinically if the drugs aren't working. But just because those biomarkers are down does not necessarily mean that I don't think it's a one-to-one correlation. So what are we going to be tracking? Well, we'll be tracking lung function, symptoms, exacerbations. So those can be done just by asking patients questions. And so, yes, I think that could be done, anywhere. We have less data on wearables and whether those, there's some data they might be able to, for instance, predict exacerbations. But I think, again, more data is probably needed in terms of using a wearable to determine like efficacy from a biologic. But here's what I will say. I do think we need more partnership for local diagnostics, generally speaking. But I will say the one diagnostic that I would love to see closer to the patients, honestly, is spirometry, which I realize is a little bit outside of this discussion, but we have so many patients that aren't even getting appropriate diagnoses. And that is something actually that I do look at when I'm tracking patients over time. We may or may not see a response, but certainly for like dupilumab, where the data's out, we did see improvements in lung function with treatment. So that is the one thing that I would love to see measured locally. I would care about and would track.
Yeah, no, I'd say that's a great point there. A very interesting question. I think it's that could we move it to a more patient-friendly site? Potentially, yes. It's just like Dr. Hunt said, we're just not quite there yet, just because the biomarker testing still, lab-based. But could we see it move to more at-home testing like we do with continuous glucose monitoring for diabetes? Maybe. Not sure if any of those are in the work just yet. From a pharmacy-based testing, in theory, point of care eosinophil testing could be offered in retail pharmacies, similar how pharmacies now do HbA1cs for diabetes. The challenge obviously is not as simple as a finger prick right now. So the tech really needs to catch up before widespread adoption. I have heard a little bit about early stage research into wearables that you mentioned, but that can detect inflammation via breath analysis or skin sensors, but I don't know if it's there just yet. And it would take a lot of, I think we're still quite a few years away, and some probably regulatory hurdles and to make sure that we're there. But it would be nice if you can determine if a patient is at risk of an exacerbation from, something that they're wearing to, really help track those real-time treatment responses and get them to care appropriately.
Thank you. Yeah, the tracking of the marker, I think, was a fascinating part of that question and how that can be used. But, I definitely would just add on and say the pharmacy can potentially play a huge role in outcomes here, and it's compliance. They're the front line. They're the ones talking. So a lot of this is going to go into probably what we're going to talk about in the next few minutes is around collaboration and how the pharmacy works with the provider, who works with the payer, and all of that. So the coordination is crucial, but the pharmacy absolutely 100% can help track the patient and improve outcomes. Dr. Hahn, maybe I'll direct this question to you to start with. And the question is, what value does biologic therapy offer in terms of avoidance of complications associated with long-term ICS use? And I'll probably expand, not to speak for the person who asked the question, but I'll probably blow that out is, maybe could you speak to that? Because we're all high level familiar with complications of steroid use, but again, is there a difference between oral versus inhaled in terms of side effects? And then really the orals are used, I think, more for exacerbations, right? So what are the long-term consequences of that? And then what is the value of reduced, and not talking about exacerbations, but reducing steroid use when we're talking about paying for an expensive biologic?
Of oral versus inhaled steroids, there's some data to suggest that inhaled steroids in some patients increase the risk for pneumonia over the shorter term. Over the longer term, likely contribute to things like reduced bone mineral density and cataracts, although that's like over the longer term. Oh, and I certainly have some patients, for instance, that complain about skin thinning. Now, obviously, if you've got multiple courses of oral steroids, you can just kind of compound all of those effects and speed up the process. So yes, we love to avoid oral steroids. And so I think to the extent that biologics can help us avoid oral steroids, that ultimately reduces a lot of long-term risks for the patients. Also things like, potentially even like diabetes. Or patients who have existing diabetes have problems with blood sugar control while we're trying to treat these exacerbations. I don't know that I fully understand the question, but to be clear, I don't think that adding biologics will, well, we don't have any data, will make it so that the patients can go off of inhaled steroids. It may be, but I haven't seen any data, and I don't know that anyone's doing that or is planning that clinical trial. So I think there's a lot of potential benefit for reducing oral steroids, but it's not quite in my mind's eye that we're going to be able to eliminate use of inhaled steroids in this patient population.
Yeah. So I think that was it. Again, not trying to interpret the question exactly. So I think it's more of the oral side. And what are the true consequences of oral steroids if we're using them intermittently for exacerbations? And then really, where does the reduction in oral steroid use rate relative to exacerbations and other outcomes that we should be looking at?
Yeah, I mean, I think it's all the things that I just I just outlined. Again, cataracts, diabetes, bone thinning, et cetera, which are not a big deal if we're just talking about a year. But you have to remember, if you think about COPD, I mean, it's a chronic disease, and if somebody gets diagnosed at 50 or 60, they might be living with us for 20 to 30 years. So we've got really long time spans where we're really trying to over those really long time spans, trying to reduce the risk of repeated oral steroid use.
Perfect. Thank you. So there's been a few questions. I'm going to try to, for right or wrong, I'm going to try to lump these together around social determinants of health disparities. Maybe Dr. Harmon, Dr. Hahn, whoever wants to jump in here. What does the data look like in terms of disparities or inequities or other things in how it impacts outcomes in COPD? So are there things that we should be looking at that are very clear causes of maybe worse outcomes that we should be focusing on?
I mean, I think this is such an important topic because when we talk about COPD management, we often focus on the medications, the clinical guidelines, but we ignore social determinants of health. We're missing half the story. So, the data tells us that lower income patients have significantly higher hospitalization and readmission rates. And why? Because they often don't have consistent access to primary or specialty care, and which will lead to delayed diagnosis and unmanaged exacerbation. And let's be real. I mean, choosing between medication and rent shouldn't be a thing, but unfortunately it is. So, out-of-pocket costs are a major driver of non-adherence. So, and those rural populations get particularly hit hard. So, when you're thinking about the higher COPD prevalence, there's more exposure to environmental triggers like farming and some industrial work, and when fewer pulmonologists in the area, you're likely going to have worse outcomes. So we talk a little bit about the pulmonary rehab side of things and just like the access to those centers. So patients have to drive hours just to find a program, and so utilization is very low. From the racial and ethnic disparities, Black and Hispanic patients are less likely to receive pulmonary function testing for COPD, which means they're going to be underdiagnosed and often start treatment later in the disease process. So I really think there's a potential equity issue there in diagnosis and treatment, because if they are, when diagnosed, are less likely to be prescribed some of the therapies despite similar disease severity. So that's some of the things that unfortunately we're seeing, so we can have the best medications and the best guidelines and the best care models. But if we don't address the barriers that prevent patients from accessing care, we're not really going to move the needle on COPD outcomes.
And not to necessarily make this a policy discussion, but as Matt just elegantly outlined, unfortunately, a lot of our patients with COPD do live in rural areas, and we're about to face a funding cliff for telehealth, which is how many of my patients in the northern parts of Michigan and beyond access care, particularly in the winter. It can be very challenging for patients with COPD to find someone who can, they may not be in a position to drive themselves, or take, we're talking about long distances. So telehealth is a lifeline for many of these patients, and this is something I worry about quite a bit.
Awesome. Thank you so much. Unfortunately, we are out of time. I will just wrap up with a challenge going back to what we mentioned earlier. Is we do need to get out of our silos. We're all trying to do what's best for our patients and our members, and there's a coordination opportunity here. And the provider plays a role in that, the payer, the pharmacy, but how we collaborate and coordinate is important, because it's important to the member and to the patient. And we can't be contradictory, we can't be confusing. And so that's a challenge, is let's get better at that. But I would like to thank Dr. Harmon and Dr. Hahn for all of their presentations and their insightful discussion. Once again, would like to thank Regeneron Pharmaceuticals Incorporated and Sanofi for their support of this activity. Now, to claim credit, please click the evaluation link. And then once the evaluation is complete and submitted, you will be able to select the type of credit you require. And you must claim your credit to receive your certificate, and then for pharmacists to submit then after to the CPE monitor. And my last plug is, as Dr. Harmon mentioned, we have a second track of this series entitled Best Practices in COPD Management. So this concludes today's webcast. Thank you for being here. Thank you for submitting questions, and I hope you have a great rest of your day.